Hello everyone, welcome I guess to the new spine center here. This is going to be a sort of a bit more of a grander opening, and we just started I guess Monday. I think we wanted to make this sort of a bridge too, and I wanted to kind of welcome all the clinicians in here and all the practitioners to be able to help if you wanted to bring your patients down here also to see if you can start transitioning them more when they start becoming a bit more independent to more of a full independence thing toward home, and even like when eventually we open the wellness center. So this is going to be the third presentation. We're going to be wrapping up the third and final presentation of our low back pain series. And this is going to be evidence-informed exercise prescription for low back pain. Again, because this is also on YouTube, I want to take a brief moment to throw out the disclaimer that the views, thoughts, and opinions over here expressed belong solely to the author, which is me. Not my employer, organization, committee group, or other individuals. And that because, again, evidence evolves so quickly right now, I want to highlight that the information I give you today is only good for today and not for tomorrow or any of the things that I've mentioned in the past. This because it's also public, I wanted to make sure that this is mostly for licensed clinicians. And if you're not a licensed clinician, you might not have the education required to be able to pick up some of these things to do on your own at home if you're a patient suffering from low back pain. And then today's objectives, we're going to start with number one, promoting evidence-informed treatment of musculoskeletal low back pain. Why is that, I guess? Because again, the results Zadro, O'Keefe, and Mayer did in 2019 showed that a lot of the physical therapy treatment and choices that we've seen in our practice guidelines are not often based on the research and evidence. You know, there was also use of some treatments that were not recommended by the guidelines in there too. So learning proper progression of heavy resistance training is going to be the next one, and it's going to differ for every individual patient because each patient is built a little bit differently. And then finally, number three, we are going to sort of do a safety screen to determine if our patients, if they are appropriate to be able to progress to resistance trainings, especially like heavy resistance training. All right, so first question here is, do we need heavy resistance training in rehab, and does it even belong in rehab? So I was curious, out of a show of hands, if anyone thinks that it does belong in rehab. And all right, that's 1, 2, 3, 4 out of 5, 6. Versus who doesn't think it belongs in rehab, you know? Versus, I guess if you didn't raise your hand, either you're eating a sandwich or you're in a food coma, right? And if you're on the fence about this, I was hoping to kind of persuade you to think that it might be something that your patients can eventually benefit from. So number two, I guess you might be able to recall that I showed you in part one of this low back pain series, you know, where our epidemic is becoming worse, and that's where I think it does belong in rehab personally. I believe it's because our lifestyles are becoming a little bit easier, and you got these NASA studies along with the really famous Dallas bed rest studies, and they did a 40-year follow-up with that too, showing that a lot of the effects of low gravitational forces or making our lives easier is actually detrimental to increasing our a risk of going back into the hospital or hospital stays. So the best way that NASA knew how to reverse the effects of this was to do heavy resistance training and reverse the effects of weightlessness and an easier life up in space during space travel. Question number two, can anyone guess how much weight these guys are holding on their heads and their necks and their arms? 60 pounds? 75. Yeah, there is a 50 in there, but it's 50 kilos. And these are 50 kilos of rice. Question number three is, does anyone actually need this much rice in their life, right? Yes. Yes, all the Asians are with me right there, yes. So why resistance training? And you know, isn't it dangerous, you think? This sign over here on the right side is, according to Brett Contreras, we can reduce the dangers in our lives by becoming strong. Also, becoming strong is something that really can't be given to us. It can't be purchased. and it can't be applied by somebody toward us in there. According to Chen et al. In 2018, greater passive behavioral coping was one of the 4 factors identified for worse back pain outcomes over the next 5 years. So guiding our clients to promote endogenous opiates, I think, is much more difficult through exercise than giving them an exogenous output. So, for example, like if you use electrical stim or ultrasounds, it's an exogenous, something that is given to them, and those are designed to be temporary relief so that they'd be able to do something. If they are interested in something more permanent, that's where the therapeutic exercise is my selling factor that I tell them, is the most important out of all the things that you do in here. And it's the foundation of, I think, what we do as physical therapists in here. And occupational therapists. And speech. There was an interesting thing where I was talking to Reggie, and he's also using heavy strength training for the tongue, because the tongue is basically a muscle. So he's beginning to apply a lot of this stuff in here, and he's trying to get readings for pressure readings on how strong and how much force the tongue can generate in the mouth. And this is for speech and swallowing evals. So you might ask yourself also, why on earth is Ken showing me this video over here? And I don't know if anyone's seen this. This is just a basic video that was taken out of the internet. So, yeah, I'm hearing some O's in the crowd. Now, for many people, this might be a dangerous thing. And yes, it might even be dangerous for me to probably do something like this. But I think that with everything that we do, the most important thing is that our body needs to be prepared to be able to do these things in here. And you got to wait for it. Wait for it. There it goes. Yes, way. But he is going downhill, so I'll give him that. Right? It's not like he's going uphill or anything. It's not like he's trying to cross a busy street or anything. That's easy, right? So the point I'm trying to make with this slide here is that there is risk in everything that we do. There is risk in applying load, and there is risk in getting people stronger in life and in the clinic. The number needed to treat for additional harm for non-serious adverse events with exercise training is about 6. And this is according to Nemigier in 2019 et al. Right? They concluded that participating in an exercise intervention increases relative risk of non-serious adverse events, but not of serious adverse events. Exercise may therefore be recommended as a relatively safe intervention, and avoiding exercise is much more harmful because by missing out on exercise and progression of this exercise, you would be, as a patient, they would be missing out on reduced blood pressures, stronger heart rate, the total physical activity and risk of breast cancer, colon cancer, diabetes, ischemic heart disease, and ischemic stroke events. This is done with 174 studies by Liu et al. In 2019. They further concluded that meeting the 2008 physical activity guidelines reduces mortality and cardiovascular risk by about 75%. So let's say you love exercise, and I have patients that come in here that tell me that, oh, I want to do more, I want to do more. So I end up pacing them because they have this boom-bust personality, and if they do too much, it's going to be like an overdose. So we're going to go through a little bit of the prescriptive part of it and how much to dose a patient using different models like the stoplight model. And the good news is that physical activity based on the amounts that go beyond the guidelines it doesn't produce any side effects or adverse risks for anything in there. So if you wanted to do between 3 times more than the guidelines or even up to 5 times more, you would obtain smaller health benefits, and it would still continue to grow, but there is no risk of maximal effect observed in even that much in there. So improved circulation and blood flow around the body. It reduces circulating fats and cholesterols. It improves muscle size and strength, stronger bones, reduced risk of falls, and improves immune system. So overall mental and well-being. I thought what was interesting is that mental health measures for resistance training had the greatest effect on mental health. And also among the physical health measures, resistance training had the largest effect on body pain. So on long-term body pain, it has probably one of the bigger things for being able to reduce long-term body pain compared to some of the modalities. So there's going to be times in our lives again when we cannot use proper body mechanics and do things the right way, as as this video shows over here. But on the left side, you're going to notice that the Chinese women's powerlifting team started beginning to use Jefferson curls, and this is where they're standing on a plate, and it's non-traditional to be able to get into this curled position to be able to start lifting heavier weights. Granted, they're lifting much lighter weights than they're using when they're powerlifting or going into competition like in the Olympics. But at the same time, when I was mentioning that when your body is not prepared to handle a situation like carrying a refrigerator or even moving into these positions over here, that's where it starts becoming more dangerous. If you've never exposed your body to these positions, you risk becoming weaker in the positions that you avoid. So they've been exposing themselves into these Jefferson curls, and this is something that gymnasts use all the time, because gymnasts have to get into these awkward bent positions all the time. They have to be strong and powerful. So it's the strong and powerful component that produces the least amount of risk that's in there. Contrary to popular belief over here, this was found on I guess either Facebook or Twitter, but this is by Rethinking Physiotherapy. Long-term strength training relaxes painful, overactive neck muscles in office workers. Doing 2 minutes a day equal decreased neck and shoulder pain intensity by about 40%. So they took about 30 female office workers who participated in about 10 weeks of high-intensity elastic strength training, doing exercises, and the control group received general information about health. They put these EMG studies on their upper trapezius and their splenius, and the upper trapezius was recorded to have, if you look at the pictures over here, a much lower reading after about 10 weeks. So heavy resistance training has been shown to actually relax the muscles that are really tight, versus if you happen to just do some of the stretches and some of the relaxation techniques. If you do these resistance training, you might be able to get even much lower and more relaxed muscle afterwards. Hopefully everyone is also able to, and I don't know if there's also a sign-in sheet that's going around, and there's also like there's a PARQ infographic that's on the table. I handed this out about a month ago to everyone and put it on their desks, and I was hoping that sometimes people would be able to sort of look through it. It's basically all the benefits that I was mentioning earlier for resistance training to show to patients, and it's also a screening tool to be able to check red flags to see if somebody is a good candidate for continuing with the resistance training. So what's really nice is we're going to go through a couple of exercises here in a couple of minutes, and these are just the most common ones you'll see basically here on the whiteboard, and these are multi-compartmental strengthening type trainings. This is going to be expansive away from the focusing in on a vertebrae, focusing in on a joint, or focusing on a certain specific muscle. This is going to be more broad. And what's really nice is that we're finding out that we can expand into things like this if patients happen to enjoy doing stuff like that. So if they like doing a certain exercise, it doesn't have to be super specific anymore. All right, so what are some of the red flags? We go through those all the time. And as clinicians, we know that it's osteoporosis, spinal cord injuries, alar ligament issues that come up after an MVA, DVTs, etc. And then heavy versus light. Most important take home from this is whether to use heavy, moderate, or even light amounts of resistance. And this includes cardiac training. So if you happen to have people on a treadmill and they start running, we have to work until failure is the key take-home point. So the resistance isn't a major factor anymore, but pushing our muscles to temporary exhaustion is now. How do we determine which type of exercise to choose from in here? That is based on the patient's subjective history, along with their goals. So to keep things simple, we'll have to fit these people into two different categories. One is, hey, are they a candidate for heavy resistance exercises, or maybe even the lighter exercises that are in here? Heavy exercise over here, you're going to notice it helps build strength. Light resistance builds more of an endurance type of a body. Heavy exercise requires less time, and light exercise, it does require more time. There are health guidelines for adults that show about 175 minutes a day. You'll see on that PARQ handout that show that in order to reduce hospital stays and risk for having major mortality issues and cardiac problems, that you'll have to do about 175 minutes a week as an elderly adult in order to be able to do that, to accomplish that. And for heavy resistance training, you'll only have to do about 70 or 75 minutes on a weekly basis. I get a lot of people who tell me they don't have time to exercise or don't have time to do a lot of this stuff. And if they switch to heavy resistance training and if they happen to do well with it, they can cut in and save themselves about 100 minutes worth of activity and still get the same benefits plus a couple of bonuses like this, like a decreased risk in cancer. They took a couple of animals and they fed them high-fat diets. The one controls were no exercise at all. Then they did light exercises over here. Then they did heavy resistance type of exercise with these animals. And there's a COX-2, you know, the enzyme that is created in a lot of the when you do exercises. And heavy exercises created the greatest amounts. So you can have almost like a threefold decrease in having cancer. So along with all the stuff that I'd mentioned earlier, it even has the ability to be able to reduce cancer risks. Thoreau et al. In 2016 found that their experiment, low physical activity, increased mixed gastrocnemius COX enzyme activity by 2.1-fold. And that was the study that found this out. It also has the greatest effect on mental health, helps reduce Alzheimer's, and then ends up increasing bone density. And that's how NASA started reversing the effects of osteoporosis in their space traveling astronauts. And so everyone gets to partner up here. So you could also try out some of these things. The first one is going to be a glute bridge, and I like starting off patients with something that they're very familiar with. And because I see the bridge happen a lot throughout the clinic, I thought this was going to be the easiest to be able to learn. It's basically a bridge, and the only difference is that it's loaded with a weight that goes around the hip area to try to promote more the gluteus maximus contraction. So the most important thing about this is that the glutes actually don't kick in the most until you're at least until the zero part. So when you're neutral in a straight position over there, anything that you get extra on top of that becomes more of a gluteus maximus contraction in there. There's also variations of this like the frog pump, which is basically with your feet together. The other one is a hip thruster, and this is sort of like the step up. This is an upgrade from the first one, the glute bridge. Basically, you'll have about a foot or so of a bolster behind you, and you'll be able to bridge upwards. And on EMG studies, this exercise has the highest amount of EMG contraction found in the glutes over here. There's different variations of this. One is with the knees, slightly more extended, and you're going to feel a lot more hamstrings contracting with that. But if you bring your knees back a little bit to where it's flexed, it's going to be much more of the gluteus maximus muscles instead. Third exercise is going to be Bulgarian split squats. Body position, again, is also key. If your knee travels beyond the toes, it's going to be more for the quadriceps and patella loading. If you start traveling behind, if your knee goes behind the toes when you're doing this exercise, it's more for the gluteus muscles. Fourth one is going to be a deadlift. Again, mostly bars stay over toes. I like keeping the weights about an inch away from the shin and then traveling upward. You're going to notice that the back is more horizontal than the squats, and that's the major difference. The more horizontal it gets, and the more that your hips travel backwards, the more you place your gluteus muscles into a position that can contract even better. This one, it's going to be a landmine overhead press, and this is again a whole body exercise. I have people with shoulder issues do this. I have people with back pain issues and sometimes even knee pain issues. Again, you're going to notice that it's multi-compartmental. It's the entire body working together as a team that goes into here. I like this because it has a little bit of freedom of movement, and then this is just like with with the rows, the landmine rows. It still has a little bit of freedom of movement, but at the same time, it's a nice beginning exercise because it's still closed chain, and it doesn't travel everywhere. Before I have people do bent rows or dumbbell rows, I like having them do this one in here too. All right. We're going to kind of go through a little bit of the exercise prescription, but we get to have some live demonstrations in here.
All right, so this is kind of around ASIS, right? Not below, because that would be a little bit painful. You have the patient grab the bar, and then it's a typical, just a glute bridge. The thing is, I think sometimes in the spine clinic with back pain, if it's too much of a contraction on the glutes, it's painful in the back. So the position of the heels is important. So the closer the heels are to his buttocks, the more the glutes will fire. The farther away, the more the hamstrings will fire. So sometimes we might start with the legs out a little bit more, so he gets more hamstring dominant activity versus glutes, just to see how he does. And then the cue is really try not to get the neck into extension at all, because that'll extend the paraspinals, right? So you want the neck tucked in to get a little bit of a posterior tilt. And go ahead and bridge away. So maybe we do 2 pillows. Good. Come down for me for a second. And obviously, if somebody has neck issues too, then you gotta be careful with this. All right, so go ahead and go up. And to Ken's point, if they don't go into full hip extension, there's no glute activity, right? So a bridge, he's getting closer, a little bit higher. Go, go, go. So that's where he needs to be. And again, if we wanted more glutes, come down, slide this way. Good. There you go. All right, lift on up. And then down. Up. And then you can also cue it when you're up there. Squeeze isometrically for 2 seconds, and then slow on the way down. So you can get the eccentric burn too. So concentric might be 2 seconds up. Squeeze 2, 1, 2, down 3. Just to intensify that burn if you wanted to. How you feel? So yeah, just right over ASIS, maybe pubis, but not below. So for the bridge itself, scapula area. When we do the hip thrust, there's a specific area that it needs to be. Good? Yeah. So for this setup, we've gone through a lot of different variations trying to figure out like what to get the scapula stabilized against. We've played with the plinth, the bolsters, what they give. They sell a specific high density foam bolster that's $190. So we're not spending that money yet. So we figured out that this works pretty well. For most people, it needs to be about 12 inches high, and that's pretty particular. So the cue is that whatever you're using to be the fulcrum, right, as he goes up, is just below the scapula. It shouldn't be on the shoulder blades. It should not be below or above. It has to be right below the scapula. So that's this placement here. And then again, we talked about foot placement. So when he thrusts up, you almost want a perpendicular line with his knee and his foot. So you good? All right, hold on to the bar. Down the way. And so when he comes up, he still keeps his chin slightly tucked in because you want the posterior pelvic tilt. He's got full extension. Now, are his legs at a 90-degree angle? Do it again. No, so he's probably getting what muscle group more than the other? Hamstring. So this time, Ken, slide your heels back about 1.5 inches. Good. Lift up again. Is that more 90? Yeah, so that's all glute. Good. 5 more. Yeah, how much weight is this? Listening. No, don't. I hear 45. I hear 65.
45.
65 pounds.
A lot of math involved here.
So we have a video on Instagram. I'm following this girl. She does 665.
665. 6 times.
She does 5 times. Yeah. Yeah. 5 times. 665. Yeah. So I mean, you can do a lot of body weight with this exercise, or a lot of heavy weight with this. Good.
Yep.
Questions on that? The 12 inches is really important. So what if you have somebody that's maybe not, body-wise is a little bit longer, a little bit shorter? You can always have them sit on something here to raise them up, right? You can elevate the plates so that it's easier to roll over, but you can modify that position. But again, 12, just make sure that it's below the scapula and make sure they get full hip extension.
Like below the inferior?
Yeah. Yeah, so both inferior ankles, just a line right below that. Yeah. It shouldn't be mid T-spine, like on their T-spine. It's just right off the shoulder blades.
Okay. So, yeah.
So then you can use this. I've used this in here, but I put a foam thing here because that cuts into a shin a little bit. But just like Ken had showed, that's fine. Right, foot placement. Go ahead and go down, and then come up. The key thing for this is that it's not a vertical drop. So he's coming down this way, right? He's descending at this plane. He's not coming straight down. So where do you feel that at? Ken?
Glutes and quads. Yeah.
Yeah.
Glutes and quads.
And I think changing form and all that stuff, you know, for the initial couple times, as long as it's pain-free and they're not having symptoms and they're feeling it in the right muscles, then it's okay. Good? Next.
So from here, I like going about an inch away from the legs and the shins. And again, you're going to notice the difference between this and the squats is that my back is going to be a little bit more horizontal versus a squat is going to be a little bit more vertical when I'm lifting this. I like telling patients to go into this ready position to where they do a lot of hip hinging, and they're going to be, when they go into this ready position, a lot of the athletes will know what this ready position is, whether they play tennis, softball, or even football in the past. The grip is actually really important. The stronger the grip, it's been known to also increase your muscular your muscular strength in getting this up. And it's also another study that when a crowd is watching, you can have between an 18 to 20% increase in your strength too to be able to lift up other weights in there too. So it's not just biological, there's also a psychological and social component to this. And this is why I like using the bigger weights in here, is because it makes patients feel like they did something something a little bit more than they actually are doing, I guess. So from here, I tell people to just go ahead and squeeze the glutes. They're going to pull up and just round off the shoulders, and that's the end of the pull that's in there. So you should feel a pull in the hamstrings and coming up. And I like doing this because it's an active hamstring stretch. And a lot of the studies are showing that the active hamstring stretches are much more effective than the passive ones, where if you had a cord and you're pulling it up, something like this to stretch the hamstring is much more superior in the end. I don't know, any...
Yeah, questions on that? That's a lot, yeah.
So, you're giving them this here, but what are you giving them at home to replicate or to simulate what you're doing here? And do you want to do that, or do you want to see them doing it here?
At home, so the question was, what am I doing at home to give the patients to sort of replicate and simulate some of these exercises in here? And a lot of times I have people start off with the glute bridge because it's something that doesn't need any special equipment. I have them learn how to contract the muscles and activate the glutes much more often, because the more that they do it, Hebbian theorem, the more that they wire together, the more that the glutes are going to start firing more often in there. And if they're able to somehow contract the glute muscles, get up from a chair, rise up from there, pick up a shoe from the floor, and just practice the form at home, then I start adding more weights over here. But I go from almost that progression from the glute bridge, then I go to the hip thrusters, then I have them sit to stand from the side of the table, and I'll usually guide them using a TheraBand around the hips. The band will pull their hips into the position that's necessary for them to kind of go into, and eventually I pull the band off, and their body should, from repetition, carry over, that same movement in there. The cue is you want to be able to feel all these exercises in your hamstrings and your glutes versus your spine. And if you're doing activities that you feel the spine doing all the work, you may not be doing it entirely correctly in there. So the more that you wire the spine and contract, the more it's going to continue contracting muscles that have already been tight, versus trying to get them to take a vacation, relax, and include the glutes and the hamstrings so that they work as a team, a whole body team in lifting something.
And I would say for most spine patients that we've been seeing, it's hard to hip hinge, right? They don't have that movement coordination. So a lot of times I'll start with squats first because the spine is more vertical, safer for them, and then transition into something like this. And If they don't have the hamstring length, that's why we have the stools. You can raise the bar length. But at home, most people, and I've been really amazed, 70–80% of the people that come to this clinic, they have access to a gym, or they have stuff at home, and they just don't know what to do, or they don't know how to use it. So even 10-pound dumbbells, you can still kind of modify this so that they're doing that same kind of motion. But as Ken said, if they're not feeling it in the right muscle groups, then you got to switch it around for them.
After all this, we're going to go through the exercise prescription, and this is where you have to work until failure, again, in order for you to actually get benefits out of this. To sort of lunge from here, and you can do this, there are variations of this. I have them start with 2 hands first. So they're basically sometimes doing a sumo squat, and from here, they just get to press overhead like that. So, just like this. And again, it's a whole body exercise. So, this one is fairly straightforward. Again, it's a closed chain exercise. The weight doesn't move around any other direction other than here, and it's just straight up. The last one is our rows, and so I just have them use the straps, and from here you basically get in that same ready position that athletes get into, and then from there your shoulder blades just kind of come together, and it's basically rowing. It's an upright row. Before I introduce open chain type of exercises on the patients, like the dumbbell rows, I like having this because it has a little bit more stability, and until they start learning more control in there. And again, any questions? Oh, Shelly?
Sorry. With regard to them utilizing their spinal muscles and not engaging their glutes, a lot of people don't have a lot of body awareness. So how are you training them first to inhibit the use of their spinal muscles versus?
There's a thing with visual imagery that I like doing. Whenever patients are having a difficult time, and this works really good with even the Jacobson's relaxation techniques, to where I have them look at their body from a third-person point of view, and if you end up cueing them with something like, okay, focus on the glute muscle or focus on the bicep muscle when you're doing an arm curl, it'll actually show that there's going to be much more growth in the area that you're contracting. So I think it's basically where your brain continues to talk and communicate with your body, and the more that the communication happens back and forth, the better the conversation, the stronger the conversation that happens. If you go just the opposite and you start inhibiting it, you start becoming a professional at inhibiting some of those muscles also, the more that you practice. It's basically like playing piano or guitar. The more you practice a tune, the better your movements start to become, even without thinking about it in there. Yeah, okay. So again, thank you. So Rocky was mentioning also the muscles when they're using in hand. They also integrate visual imagery into it.
I think it's important that it's not black and white, right? So it's not like, okay, your motor control's good, now you're going to start strengthening. It's always that gray area. So I think as long as, if it's a patient with 20 years of back pain, stuff's healed for the most part, serious issues. So it's how you frame that exercise. It's like, wow, if you can get this 70% in your glute and hamstrings and maybe 20 or 30% in your back, and you feel some stiffness there, that's okay. So it starts there where, okay, so I can feel a little bit of pull in my back and be okay with that. Absolutely. Because again, it's not a 2-day acute herniated disc with foot drop, right? That'd be a different case scenario. But some of the more long-standing issues, I think they need that reinforcement that it's not going to happen overnight, and that you're looking at that gradual percentage of muscle activation.
So last 2 slides over here, and we can wrap it up. We're going to go through some of the prescription and how much to dose our patients, because I think that is a biggie. Okay, so this is the stoplight model I had mentioned earlier. In exercise order, you want to, when you evaluate your patient, you want to be able to first prioritize the area that they're going to focus on, because it is multi-compartmental. It's all these other body parts. You want to put the exercise to focus on the area that they're having the most difficulty with. A lot of times if you focus on function, and they say that they're having difficulty getting up from the commode, getting in and out of their car, being able to reach overhead for an item or carry, I don't know, if you're Asian, 50 kilos of rice from the car to your kitchen counter, then they will end up bringing that up, and that's how you develop your exercises. Rest periods for long, heavy lifts are going to be about 2 minutes because you want to be able to regenerate enough strength, and you want to be able to not be too fatigued. A lot of times if your body's too fatigued, you're going to notice at the end of the games when you're watching basketball or football, a lot of injuries may end up happening when the athlete starts becoming more fatigued in there. And up to 10 minutes of a rest break period in between if they want to do a personal record, for a 1 rep max, for example. Now, because I don't like doing 1 rep maxes with patients, and it could be detrimental to their spine if we did something really heavy, I like using this stoplight model that's over here. So you're going to see the green light is what I tell patients. If you feel pain, it's actually more important to feel pain during rehab than to feel zero pain. Some of the worst outcomes come from feeling zero pain during a treatment time. If you feel, of course, 7, 8, or 9, where you're in like the red light zone, that's also not very good outcomes for a rehab program. Somewhere in between 3 out of 10 and 4 out of 10 is what I tell patients that, hey, this is what you want to do, and if you don't feel this much, that means you're not teaching your body how to adapt to anything. I look at it as inoculations. Most people think that when they get the flu shot, it's to keep them from getting sick. No, if you get a flu shot, it's designed to actually save your life. You get a sample of what the virus is for that year and that strain. Then you end up having your immune system learn how to deal with it so that when you do get that strain, it knows exactly what to do and it can take it out and you live another year. So most people treat this as they try to avoid, they try to avoid pain just like they try to avoid getting sick and getting the flu shot, so to speak. If you don't expose your body to pain, it actually has no idea what to do with it, and it ends up freaking out the first time it's exposed to it in a while. And this is why I think that back pain is worsening overall, and not just in the United States, but now globally in there. 16 total repetitions we found out, and this is according to Brett Contreras and Cordoza. It's a new book that they just had out. I guess last month is when it was released. 4 sets of 3 different types of exercise with 5 repetitions each. Eventually going into failure to where they can't do another one, or you need to assist them with getting the last repetition up, is what is supposed to be key. So deconstructing to reconstructing is actually the key. You have to break down and produce inflammatory responses. You have to produce pro-inflammatory cytokines in the system in order for any growth to happen and in order for the body to adapt into anything. If you do not, your body has no reason to adapt. So sets and reps, about 1/3 of the sets would be heavy, 1 to 5 reps is appropriate for that. 1/3 of the sets the reps would be medium, and they should be able to do between 8 and 12 repetitions, and then 1/3 would be light repetitions, like for example in a cool down where they're doing about 20 reps until failure. Training a frequency of about 2 times a week to 3 times a week is the very minimal in order to get the smallest amount of change and difference in a body. If they do more than that, they actually get more benefits out of it. But in order to get the smallest, tiniest change, about 3 times a week is necessary. If they want to maintain what they have, about 2 times a week without a whole lot of change is necessary for just maintenance. Yeah, so protocols using painful exercises over a small but significant benefit over pain-free exercise in the short term. And this is with a moderate amount of evidence, according to Seng et al. In 2014. So with this primary emphasis on functional restoration. So whenever we ask for a pain scale, like how much pain are you feeling today, it's been known to end up amplifying their pain and worsen their pain in the future for the next 5 years. If we focus on, hey, what's your PSFS score on when they first come in? Is it easier to do this now when you put your shirt on? Is it easier to put your shoe on your foot when you bend your knee? That's been shown to actually help decrease and modulate pain to go downward instead. So I like asking people, hey, how easy has it been to get up the stair step or get out of your car lately? Before I like asking the pain scale, just to put the focus on that, because the first thing that you bring to somebody when you first present something, it's the first impression, and that has the longest lasting effect in there. So there's other areas of exercise prescription. This one I like. which somebody took a modified Borg scale and did his PhD around it, to where he changed it a little bit. And if you get about an 8.5 in there, or an 8 in there, then that's about the kind of report back you want to get. So instead of doing a 1 rep max and then doing about 70% or 80% of that, because 1 rep max can also be dangerous and you can end up injuring a patient, I like using this Borg scale now to find out, okay, how much exertion was that? I recently worked with a cardiac patient who continuously gave me his Borg scale because he had cardiac precautions. And by the time he was done, he was also lifting about 70 pounds off the ground and doing 65-pound overhead presses once all the stitches and all the things started healing and recovering around his chest, and he didn't have any precautions anymore. All right, so the selling factor for anyone on the fence, this is it says 1,000 words. They say it can be represented by a picture. This is from Physio Digest. It is an interesting study that showed a hypertrophied cruciate ligaments in weightlifters. The conclusion of this is that this research is the first description of cruciate ligament hypertrophy, which is probably caused by heavy lifting that was started about the age of puberty. So knowledge of the phenomenon of cruciate ligament overgrowth is vital for orthopedics, because possible changes for the cruciate ligament mechanical properties and three-dimensional orientation may be the incidence of trauma and reconstruction procedure techniques. So with resistance training, you can actually start increasing ACL density, knee density. For the first time, I guess like I mentioned earlier, spine patients where the discs are actually thicker, the knee cartilage is more robust than the people who are non-runners. So when they followed runners versus non-runners for 10 years, the non-runners actually degenerate their knees faster than the people who are doing the running. You know. So, all right. Well, thank you very much. This is the end. In here. Woo! I like this slide a lot, but the doctor of the future will give no medicine, but will interest his patients in the care of human frame and diet and the cause of prevention and disease. You know, so Dr. Yatendra Kumar, 2019, and this is taken off that site in there. Yeah, exercise daily, and if there's any questions that come up, either Mike Leal is a really good resource because he does a lot of exercise reading through, and my extension is over there for any questions that come up anytime.